definitely. So over the years, the bugs have developed resistance, and now we find it very difficult to manage them in their nick position. So the whole thing of tackling infection after fracture fixation and also in osteoarticular infections has become very tricky because not every antibiotic is responding, and most of the bugs are turning sour to the antibiotic. So we need to have a scientific approach how to tackle from the very beginning, starting with how the wounds are to be classified, going into the details of the bacteria and what antibiotic to do, what surgery procedures to be followed, what protocols to be done, all needs to be understood very well and practiced very often. We started this attempt of conducting a course in these times of COVID, and this is our second course, which is going to start today. So that I'm sure all of you will benefit immensely by following all the lectures carefully. With that, I would ask Dr. Agashe to introduce today's module. Dr. Agashe.
Thank you, sir. I'll share the screen now. Can you see my screen?
Yes, we can.
Yeah. Welcome to the online fellowship on osteoarticular infections. I am Dr. Vikas Agashe, and I'll take you back to about 11 years when WHO declared that antibiotic resistance, no action today, no cure tomorrow. So I have modified it as orthopedic infections, no care today, no future tomorrow. So one has to be very, very careful about these infections. Now, some recent papers have reported very high infection from India as well as some developing countries, with open fractures rate being 30 to 50%, and even in closed fractures, infection rate as high as 12%. This is just to quote one paper, 156 open fractures with almost 60% infection rate. Similarly, another paper, 130 patients, 52% infection rate. Even after open fractures, the infection rate has been almost 12%, and after plate fixation, it has been almost 18%. As Dr. Thakur said, the antibiotics are often misused, and that's a major area of concern. And we will like to put more stress on antibiotics, especially in the second module, when our infectious disease specialist will discuss this. But before that, I would like you to read this paper, Trends and Patterns of Antibiotic Prescribing, a 10-year observational study. And this paper has brought out tremendous lacunae in using antibiotics. Now, we often say that someone has to do something. Now, what is that someone? Who is that someone? That someone is we all. And we all, let us join our hands in this war against osteoarticular and soft tissue infections. Now, it's my honor to introduce the faculty. Dr. Thakur, who just spoke to you, it is said that a person is known by his company. So as regards Dr. Thakur is concerned, he is known by the books. He has got 5 important orthopedic books to his credit. Very, very popular books. Dr. Aditya Menon, who is a consultant at PD Hinduja Hospital with me and has done several fellowships. He is also an honorary secretary, infection section of Asia Pacific Orthopaedic Association, and he represents India in European Bone and Joint Infection Society. And needless to say, he has several publications in trauma, arthroplasty, and osteoarticular infections. I am Dr. Vikas Agashe. I will also be one of the mentors. I have been working on this osteoarticular infections for last more than 20 years.
navicular bone.
We have 8 fellowship modules, and we will cover them over 8 weekends, except the weekend of 26th, because we will have our Viroc Global during that time. We also will be helped by Dr. Dalvi, who is a spine surgeon, Dr. Bimal Modi, who is a plastic surgeon, Dr. Mandar Agashi, who is a pediatric orthopedic surgeon, and Dr. Aisha Sunawala. Dr. Aisha Sunawala, who is our infectious disease specialist. Now, what is the basis of managing osteoarticular and soft tissue infections? This is what I'm discussing is not published anywhere, but I always consider this as a 6-legged table and weight on the top. Now, that 6-legged table is important because every leg of that table is important. Even if one of the leg breaks, it doesn't remain stable. So, appropriate diagnosis using appropriate tests, debridement, radical when indicated, obtain a soft tissue cover. What is important is convert an infected scenario into a closed, uninfected scenario as early as possible. We often need support or fixation. We need to give appropriate antibiotics, and we need to give local measures like local antibiotics or negative therapy. All that is very important, but far more important is the tabletop, and that is a compromise. So many times we have to do compromises as regards infections are concerned. That means right compromise at the right time, like debridement, re-exploration, like amputation, because if you don't do it at the proper time, the whole tabletop will tilt. Last but not the least is the dead weight on the table, and these are comorbidities like diabetes, smoking, malnutrition, and if that increases, then the tabletop will break. So consider management as this 6-legged table with a tabletop and dead weight on the table. If you follow this theme, you will find that managing osteoarticular infection becomes very, very logical. So to conclude, friends, this fellowship is not just how we learned, but how we are still learning. It is not just what we have learned or what we know, but how we are learning. With that small introduction, I will today's module, we will be discussing open fractures. So we all know what is an open fracture. Can you see my screen?
Yes, sir. So before we go ahead with the talk, could we have the introductions from the delegates?
Yes. Let's have introduction. I'll stop sharing. So let us meet everybody virtually. Dr. Aditya?
Yes, sir. The first one, if you could unmute yourself and start your video screen, Vivo 1917.
I think all of them can start the video screens.
Yeah.
But
yeah,
they unmute sequentially.
Dr. RAV, are you there? I can see your name first.
Please start your video screen.
Maybe one by one,
like
start
to meet
unmuting
you
and
at
introduce
least virtually.
Recording in progress.
Dr. Menon, shall we start?
Yes, sir. Dr. Subramania Gandhi.
Sir, have you joined from 2 devices? There is an echo. Somebody has joined from 2 devices. Can you just leave one device?
Okay, the next person.
Okay. Dr. Aniket, if you could introduce yourself.
Good evening. Myself, Dr. Aniket Wankide.
Hi, Dr. Aniket. If you could just tell us where you work and
currently I am working in Sevagram Hospital, Mahatma Gandhi Institute of Medical Sciences. I am working as an SR over there. Last 3-4 months of my SRship are remaining. I am highly interested in this module, so I applied for this fellowship of infection. I'd like to learn about it. Thank you.
Well, welcome to the course. Dr. Tanay, if you could unmute yourself.
Yes, good evening, everybody. I am Dr. Tanay Goyal. I am from Ambikapur, Chhattisgarh. It's a Tier 3 city. I have done my undergraduation from Pravara Medical College, Loni. And thankfully, I was under Yadkikar sir, who is here. He was my teacher he was associate professor in orthopedics when I was an undergrad there. So it's a pleasure to see him here again. I did my post-graduation from Vasantrao Pawar Medical College, Nashik. I have had the fortunate experience of hearing Dr. Agashe sir in a conference in Nashik in my second year of post-graduation, sir. Then I went on to do a fellowship under Dr. Rajendra Chandak sir, Nagpur, for complex trauma and reconstructive procedures. And I will come back to my native town, and I'm looking for a job in Government Medical College here, sir. It's a pleasure to be on this platform, and I am really looking forward to learn from Dr. Agashe and everybody else here to have better knowledge and to do better things for the patient. Thank you, sir.
Thank you, Dr. Tanay. Dr. Yadkikar, sir, if you could continue from where Dr. Tanay is.
Yes, sir. Good evening, sir. I am Dr. Srinivas Yadkikar. I am from Maharashtra. I have done my post-graduation from Tanay's College, that is Pravara Institute of Medical Sciences. Presently, I am working as a professor of orthopedics in Jaipur National University, Jaipur. And I have seen Agashe sir's demonstration, beautiful demonstration in way back in 2010 in Nashik, Maharashtra Orthopaedic Association conference, where he demonstrated the fasciotomy techniques by its model, and it was wonderful. It was wonderful to see him. So we learned a lot of things from him that time, and still we are learning. And it is pleasure to see sir.
Thank you. My colleague Dr. Patankar had prepared that model. Thank you for reminding us.
Yes, sir. Yes, sir. Yes, sir.
Yeah. Thank you. Thank you.
Thank you, Dr. Srinivas. Dr. RAV, if you could unmute yourself. RAV Lustro. Dr. RAV, can you hear me?
Hello, good evening. I am Rav or Ronald Alvin Lustre. I'm an orthopedic surgeon and traumatologist here in the Philippines. I hope to learn everything from all you, my fellow doctors. I also hope that I can come there and train from you, and also you come here and visit our country, my country. Thank you, sir.
For sure.
Thank you. Thank you.
Thank you, and welcome to the course. Dr. Mane.
Hello, sir. Myself, Dr. Bhavichan Mane. I did my postgraduate from Narayan Medical College, Andhra Pradesh. And right now I'm working as a consultant at a World Trust Hospital, which is located near Vijayawada. It's an honor to be on this platform, learn new things. And my aim is to provide good quality care to the patient by using this platform. Thank you, sir. And I think, Aditya, sir, I met you at Bangalore Cadaver course like 4 years back.
Yes, I remember that. Yes,
Yeah.
absolutely. We met there.
Yeah, nice meeting you again, sir. Thank you.
Same here, same here. Good.
Thank you, sir.
Good. Thank you. Dr. Alkitmi.
Hello, Assalamu alaikum. Good afternoon, everyone. I'm Riyad Al-Githmi, orthopedic surgery resident from Saudi Arabia. I'm in my 4th year in residency program. Inshallah, I hope that I will get benefit from this platform and fellowship, and I'm appreciated for your efforts. Thank you very much.
Thank you and welcome to the course. Dr. Balvishnu, could you please unmute yourself?
Hi, sir. Good evening, sir. I am Dr. Balvishnu from Kerala. I am currently working as a consultant in a private hospital here in Kottayam part of Kerala. I would join this course to come to know about the recent advances in osteoarticular infections and newer regimens and all. So thank you for this wonderful opportunity.
Thank you and welcome, Dr. Balvishnu.
Thank you.
Dr. C.B. Manikam.
Yes, sir. So good evening, sir. Actually, I'm Dr. Brahmanyam. I'm logging from my brother's mobile, so that's why. Thank you for the opportunity, first of all, sir. Actually, I'm from Tamil Nadu, Chennai. I'm working as an assistant professor in a medical college. I've completed my MS in 2017, then did the fellowship in Elizaro with Dr. Vasudevan sir from Palakkad. The day-to-day scenarios which we commonly see here is infective cases, and looking upon for the illustrative next 8 weeks to learn more and to keep learning about these things, sir, which is a very dreadful condition in orthopedic, the infective management. Thank you for the opportunity given, sir.
Thank you and welcome to the course. Dr. Aisha Mohapatra, if you could unmute yourself. I don't think she's there, right? Yes, she is.
Namaskar, sir. Good evening. Sir, I'm having some video issues. So, sir, myself, Dr. Aisha Mohapatra, I've done my MBBS from SCP Medical College, Cuttack, and I recently completed my post-graduation in the month of January 2022. And I'm really, so since I'm going to start my SRship in some months, so I'm really blessed and honored to be having the opportunity to be taught and taught by interaction with all the stalwarts of orthopedics here, sir. So thank you for the opportunity.
Thank you, Dr. Aisha. Dr. Yogesh Malik. We can't hear you. You're muted, Dr. Malik.
Hello, good evening, sir.
Good evening.
Hello, sir. Myself, Dr. Yogesh. I am doing my from Haryana. I did my from Jawaharlal College, Ajmer, and then I just found new concepts in gastrolitis and other bone infections. So I joined this course. Thank you, sir, for this opportunity.
Thank you, Dr. Yogesh. Dr. Somasundaram Sekhar. Dr. Sekhar, are you online?
Yes, sir. Yes, sir. I'm online.
Hi.
Can you hear me?
Yes.
We can. We can't see you.
My video has been disabled. I'm not able to switch it on.
Okay.
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 Okay. Hello, sir. Good evening, everyone. I'm Dr. Somasundaram Shekhar. I'm an orthopedic surgeon from Bangalore. I'm a consultant arthroscopic and joint replacement surgeon, mainly lower limbs. I did my post-graduation from MS Ramaiah, following which I've done fellowship from KEM Mumbai in joint replacement and Miyot Hospital, Chennai in lower limb arthroscopy and sports reconstructions. And I was in NUH Singapore for 1 year for adult reconstruction, hip, knee, and foot and ankle surgeries. So currently I'm practicing in Bangalore, sir. And I have seen a few cases with infections, and I usually take the help of a microbiologist. But then I saw this course and I thought, okay, it'll definitely help me to fine tune how to manage the osteoarticular infections.
Great. I hope this course helps.
Yes, sir. Sure, definitely. I'm looking forward to it. Thank you very much.
Thank you, Doctor. Dr. Akshay. Dr. Akshay, are you there?
Yes, sir, I am here. I'm having some issues with my video.
Okay.
Sir, I am a senior resident working in JJ Hospital, Mumbai. I completed my post-graduation in JJ Hospital itself. I'm actually a student of Dr. Sangeet Gawale, sir. So, week in and week out, I'll be hearing Vikas Agashe, sir, in various platforms in BOS, So once I got to know that he's leading the fellowship program, so I was very keen in joining.
Thank you.
Thank you.
Great. Welcome to the course, Dr.
Thank you.
Dr. Tanay Goyal. Dr. Tanay?
No, he has already spoken, right?
Oh, sorry.
Yeah. It would be Harne.
Dr. Harne.
now.
Hello, good evening, everyone. I'm Dr. Nandakishore Harne from Gondia. I did my PG from KMC Manipal. Currently, I'm pursuing my fellowship in Agash Hospital, Kurla, Mumbai. I got inspired from Vikas Agadi sir to take this course in osteoarticular infections. Thank you.
Great. Welcome, Dr. Harne.
Ayansh.
Dr. Ayansh.
Yeah.
Probably not online yet. Dr. Durgesh Patidar.
Yes, good evening, sir. Good evening, Agase, sir. I am here from Indore. I did my post-graduation from IMCH Indore. Currently, I'm working as a consultant in Badwani, nearby Indore. And currently facing problem of compound injury and distal femur as well as distal tibia. I used to know that Agase, sir will help me to come out from the infection. So I joined this fellowship. Thank you, sir.
Great, welcome. This iPhone 13 Pro Max, I can't see a name there. So whoever's using iPhone 13 Pro Max.
I think let's go to Surya
Okay.
Prakash.
Surya Prakash, Dr. Surya Prakash. Okay.
Good evening, sir. I'm Dr. Suri Prakash, currently working as a consultant in Medicover Hospitals, Kakinada. We see a lot of compound injuries in our daily practice. So I thought of enriching my knowledge with these courses. So looking forward to have much more fun in learning from you. Thank you, sir.
Thank you and welcome, Dr. Surya Prakash.
Thanks.
Dr. Sandeep. Dr. Sandeep, are you there? Or we go ahead to Dr. Subramanya Gandhi?
Sir, I introduced myself from my brother's mobile in the name of Sibi Manikam.
Okay, got it.
Actually, video is not working for me, so that's why.
Okay, fair enough.
Thank you.
All right. Dr. Suranjan Nath, sir. We can't hear you, Dr. Suranjan. I think he's locked out. I think we're done with the introductions unless we've missed out someone. You could unmute yourself before we start the first talk.
Tarun. Last one seems to be Tarun. Okay, if we have not missed out anyone, let's start with the course. I'll start sharing the screen. So we have broken this into small talks. At the outset, let me say one thing. If you and me always agree, one of us is unnecessary. In the sense, there are bound to be different opinions. No opinion is bound to be 100% correct, but we will basically discuss various options, advantages and disadvantages of every option. So we all know open fracture is the one where there is a break in the skin which allows direct communication between fracture site or hematoma with the external elements. I mean, this from our final MBBS days or second MBBS days, we have been listening to this. This is an extremely challenging situation as quoted in several papers. Now, how do we classify this? This, I take you back almost 40, 50 years ago. Gustillo and Anderson in 1976 classified this, and this is the most commonly used classification. This was a milestone in management of open injuries and essentially is brought into focus the importance of soft tissues and wound contamination. They classified it as type 1, type 2, type 3, and not as stage 1, stage 2, stage 3. That came in a little later, and ideally it should be classified as type 1, type 2, type 3. It was a retrospective and prospective study over almost 15 years, and they had studied almost 1,000 plus patients. In the retrospective study, the infection rate initially was 12%. Later on, with efforts from their side, it came down to 5%. But in type 3, as we call today, it was 44%. In the prospective study, they decided the protocol of debridement and copious irrigation, no primary internal fixation. This is what they proposed in 1976. And primary closure for type 1 and type 2. That brought down the infection rate. And secondary closure for type 3. And that brought down the infection rate in type 3 from 44%, which was there for retrospective study, to 9% in their prospective study. After about 8 years, they subclassified this into type 3A, type 3B, and type 3C, which we all know. And we all know that if the wound is small, very small, then it is type 1. If the wound is moderate size, 1 to 10 centimeters, is type 2. And if it is large, then it is type 3. If a soft tissue coverage of the bone is possible, then we call it type 3A. If the bone cover is not possible, then it is type B. And whatever may be the cover, whatever may be the size, if there is a vascular injury, it is type 3. And the infection rate generally goes on increasing as the grade or type increases. They noticed that the pathogens changed significantly over a period of those 10 years. First 15 years, the gram-negative bacteria were only 24%. Later, 8 years, they noticed that the gram-negative bacteria contributed almost 77% of infection. And therefore, initially they had all used to use only cephalosporin or first generation cephalosporin. They changed over to cephalosporin plus aminoglycoside or third generation cephalosporin, which was useful for gram-negative bugs also. There are several drawbacks to Gustillo. First and foremost, there is a tremendous inter-observer variation. Secondly, it depends mainly on the size of the wound and does not take severity to injury, severity of injury to skin, bone, muscular tendinous units, as well as contamination. Just to give an example, this standard type 1 injury, inside-out injury, is relatively less harmful as regards infection is concerned. But compare it with some other types. This is a case that I had sent you all. Patient had a fall in garden and contaminated with soil and possibly manure. Now, obviously, you can't compare both these. You can't think of these two almost with as similar injuries. Similarly, this patient has a small wound, maybe type 1 or type 2. But you look at the bony injury And she presented with severe swelling, hematuria, raised creatinine, myoglobinuria, obviously had an compartment syndrome with crush syndrome. So you can't say that these are all similar. Both have very small injuries. So as per the Gustilios classification, it will be considered as grade 1 or at the most grade 2. Another injury, I am sure all of you have come across such injuries. A small external wound, but markedly comminuted fracture and loss of the bone. And therefore, this classification has undergone several modifications. And a due importance needs to be given to contamination as well as signs of high energy mechanism. Many of the experts classify this or consider this as type 3 injury directly if there is a high injury or high energy mechanism or a significant contamination. So finally, the factors which modify the grade are size of the wound, no doubt, but also contamination. If it is contaminated by sewage or farmland or oral injuries like bites, they take you to type 3 directly, or fecal injuries, they take you to type 3 directly. Then soft tissue coverage, whether it can be approximated or not. Bony injuries, fracture pattern, comminuted fractures, loss of bone, all that would be straight 3. And if it is delayed more than 12 hours, they presented more than 12 hours, then again it adds to what we often call as comorbidity. But finally, this is a language with which most of us communicate to each other as regards the results of fracture treatment are concerned. And it is reasonably simple. One has to remember that a downside of Elizaro is it tries to contain a limitless variety of injuries, injuries, mechanism, and severities with a small number of discrete categories, 1, 2, 3, 3A, 3B, 3. And as I said, there's a poor inter-observer variation, reliability. It does not address the question of salvage, and most important, doesn't help too much as regards taking a decision as regards treatment is concerned, treatment of soft tissues as well as bony treatment. So therefore, we go to the next I wouldn't say classification or score, which is Ganga score, and developed by our friends from Ganga Hospital, Coimbatore. May I request Dr. Aditya to explain a bit more about Ganga score? I'll stop sharing.
Thank you, sir. Thank you, sir. I'll just share my screen. Like sir said, Ganga score was developed by the orthopedic and plastic surgery teams at Ganga Hospital in 2015. It's called the Ganga Hospital Open Injury Score. It basically consists of 4 systems which were not present in the Gustello-Anderson system. What they realized was Gustello-Anderson system was based more on the skin loss and the defect in the skin and did not take into account the muscular tenderness or the bony injuries or the clinical factors associated with the injury. So they've said that or stated in their study that we must look at 4 things. One is the covering tissue, that's the skin and subcutaneous layer. Then come the skeletal structures, the functional tissues, and the comorbid factors. So in the covering structures come your skin and fascia, then come your bone and joint. Each of them is scored from 1 being less severe to 5 being extremely severe injury. Then comes your functional unit, that is the muscles, tendons, and nerves, again scored from 1 being a minor injury to 5 being a very severe injury. And comorbid factors. They have explained 7 comorbid factors, which I'll describe in a few slides. Each comorbid factor is given 2 points. So the other 3 segments have 1 to 5, whereas each comorbidity is given 2 points each. Now coming to the first section, that is the skin and fascia, that's the covering tissue. Logically, 1 would be less severe. That means wounds without skin loss, like a CLW. If it's not on the fracture site, that is away, graded 1. If it is exposing the fracture site, but there is no skin loss, it is given a score of 2. Similarly, if the wound is associated with skin loss, but away from the fracture site, it's scored 3, whereas the same skin loss, if it's on the fracture site and exposes the fracture to the environment directly, it's given a score of 4. A circumferential wound with skin loss would be given a grade 5. So logically, it goes from a small CLW away from fracture site to a circumferential injury from 1 to 5. Similarly, bone and joint, a transverse and oblique fracture with a butterfly fragment, with or without a butterfly fragment less than 50% circumference would be 1. Butterfly fragment more than 50% would be 2. A comminution or segmental fracture without bone loss would be 3. Bone loss less than 4 centimeters would be 4. And a bone loss more than 4 centimeters would be graded 5. Again, here it's a logical sequence going from less severe injury to a more severe injury with bone loss more than 4 centimeters. Coming to the third aspect, that is the muscles, tendons, and the nerves, that's the functional unit. A partial injury to a muscular tendinous unit would be 1. A complete but repairable injury would be 2. Irreparable injury or a partial loss of a compartment or complete injury to posterior tibial nerve would be 3. Now here, if you could go back to a few older papers where we would assess the sensation on the sole, which is supplied by the posterior tibial nerve, it was said that if the sensation is not there, then amputation should be considered. But here out of 5, that is graded as 3. So it may not be the only determining factor. That is what this paper is trying to tell us. There are various other aspects as well. Loss of one compartment is graded higher than a complete injury to the posterior tibial nerve. And the last would be loss of 2 or more compartments or a subtotal amputation would be graded as 5. Now, coming to the comorbid factors, by and large, we think comorbidities means diabetes, hypertension, but here they've included a lot of clinical aspects which would have a massive bearing on the outcome. If the debridement, the interval between the injury and the debridement is more than 12 hours, or there is sewage contamination or organic soil contamination, farmyard injury. Third would be age more than 65. Fourth would be increased anesthetics risk. So here the other diabetes, cardiac issues would come into picture. Then comes the injury severity score more than 25, or the patient has an established fat embolism, hypotension with BP less than systolic BP less than 90, or any other major injury to the same limb or compartment syndrome. Each of these points, if present, is given 2 points each. Now, the total is calculated from each section, and if the total is 14 or less, it is said that the chance, every attempt should be made to salvage the limb. Now, the important point to note is what the team at Ganga Hospital has said, that this score should be done at the end of the debridement, because there are times when we excise a lot of dead muscle, dead tissue, dead bone in the debridement. The score may be much less at presentation, but after the debridement, if we have a bone loss or significant muscle which has been excised, then the score would be higher. So every attempt should be made to score at the end of the debridement. So a score of 14 or less, the limb should be salvaged. They have given a gray zone of where the score is between 15 to 16, where they've specifically given this because what they say is depending on the socioeconomic factors, depending on the expertise of the team, the area where the injuries happened, the team may decide to either salvage or think on the lines of amputation. And if the score is 17 and above, then one must strongly consider amputation, though it is not a rule. So the advantage of this Ganga score compared to a gustula intestine is at the end of the debridement, we have a score by which we will have a guideline as to which way the patient and the limb is heading, and we can have that conversation with the family as far as the prognosis is concerned. Even a score of 17 and 18, an attempt at salvage may be made, but it would be a more complex reconstruction, and that is how the planning must go ahead. So to explain this Ganga score in a clinical scenario, this was an 11-year-old boy who fell from the 11th floor, had a fracture of the right radius and an open injury of the proximal tibia fibula. The radius was nailed. An external fixator with a flap was done for the tibia. It was a grossly contaminated injury. This was all done elsewhere. 10 days after the injury, the patient came to us in this condition. The flap showed areas of necrosis, hyperpigmentation, dusking around the margins. There was a knee spanning external fixator in place. The necrosis and discoloration, like you can see in these pictures was on the flexure and the dorsal aspect, extending far beyond the margins of the flap. Pin tracks looked infected. We went ahead, explored. There was significant amount of pus deep to the flap and the surrounding tissue. Extensive debridement was done. This was the amount of necrotic tissue that had to be excised. And this was the clinical state at the end of the debridement. We could salvage the medial gastrocnemius flap because the muscle itself was healthy and vascular. The surrounding necrotic tissue was removed. The bone was exposed at this stage. The cultures grew multi-drug resistant Proteus and Klebsiella, started on meropenem and cotrimoxazole. Now, if we applied Ganga Hospital score to this patient at this stage, this patient had a circumferential wound loss with skin and wound loss, which would give a grade of score of 5. The fracture pattern was stage 1, scored 1, because it was an oblique spiral kind of a fracture with less than 50% involvement. Now the question was, there was an exposed bone. If we did an excision at this stage, that would mean the defect would be more than 4 centimeters, and automatically the scoring would go to 5. From 1, it would jump to 5, because there was almost 6 centimeters of bone that was exposed and devoid of soft tissue cover. The medial gastrocnemius flap just about covered the fracture side, whereas the distal shaft was completely exposed. There was a partial injury to the muscular tendinous unit, which was scored at 1. From the history, the patient came to us 10 days later, but the history was there was a 12-hour delay in the debridement, and there was significant contamination at the time of the fall. So those points were 2 each, so 4 points here. The score came to 11 without bony excision and to 15 with bony excision. The question for us was, if we excise, we were heading towards an amputation in a young boy, which is not what we would ideally want. So our attempt was to try and salvage that piece of bone, shove it into the proximal condyle, get stability with the fixator, and try and get cover so that we can salvage that bone and reduce the number of surgeries required. As far as the sensitivity and the reliability of Ganga score is concerned, the higher the score, the higher the chance of amputation. Almost 100% at score of 18, the reliability would indicate that an amputation would be required. They've also described that how do we manage the soft tissue? If, like here on the right hand side, if we can focus on the right side, which I have marked out, the score was 5. What they suggested, with significant amount of skin soft tissue loss, bridging vacuum therapy or negative pressure wound therapy must be used, followed with a delayed flap or a staged reconstruction. So one should not attempt primary closure is out of question. One must be sure about the wound status before attempting any closure or any flap. So accordingly, we applied a knee sparing fixator with a C-clamp across the proximal tibia. We got good wound bed, applied negative pressure wound therapy. This is clenched choice wound where the holes in the foam give dome-shaped granulation tissue, which is a new technology which has come up because it helps in auto debridement with the negative pressure. And we got good granulation. A local fasciocutaneous flap was done to attempt to close the tibia, but wound looked good, but there was still an amount of, an exposed segment of tibia which constantly worried us, and the vascularity was questionable. It was already 10-12 days since the patient had come to us, and keeping a bone exposed for that long is not the ideal scenario. So we decided to bite the bullet at this stage. In spite of the score heading towards 15, we excised that bony segment. And after removal, we realized that that exposed bony segment had hardly any vascularity. We excised till we got fresh bleeding edges of bony edges. Skin graft was put on the rest of the area. A cross-leg flap was done by Dr. Bimal Modi, who will describe this technique more in detail when he has his talk in this module. The fixators are applied across both the legs. It is an inconvenience, but it's an extremely useful flap where, especially in pediatric cases or where there is gross soft tissue loss on the same side, a free flap would have been difficult here because there was a lot of trauma to the local tissue. Plus, there was a lot of atrophy. The limb was narrow, thin, so a local flap was not there. So a cross-leg flap was a very viable and useful technique at this stage. And that's how the wound was covered. We decided not to do anything as far as the bone transport is concerned. The patient had grown multiple gram-negative, multi-drug resistant organisms, was on polymyxin eventually. So we decided to wait as far as any bone grafting procedures concerned. We did not want to burn that bridge right now. But with good stability, a good flap, we sequential X-ray started showing bridging callus across that massive 7-centimeter defect without doing anything. That's an advantage in pediatric patients especially. And this is the X-ray at 1 year. You can see that there are 2 columns of bone forming medially and laterally, and we can see that on the lateral X-ray as well. These are the clinical pictures, and these are the X-rays from today morning. So it's 14 months. This was taken today morning itself. The columns have started hypertrophying. The patient is walking independently. Stop the video. Patient does have shortening. Eventually, we will have to do a lengthening at some stage, but currently we want the nutrition, the local soft tissue to improve even more, the bone to hypertrophy, and then we go ahead with that. So the Ganga Hospital score has taken into consideration a lot of fallacies or points which are missing in the Dasilo-Anderson, where they've given us a scoring system which you can use for prognosis, used to decide what soft tissue management should be used, whether a skin graft, primary closure versus local flap versus a free flap. And it's very sensitive and specific in guiding us towards salvaging versus amputation of the injured limb. Thank you.
Thank you very much, Dr. Aditya. If anyone has any question, you can either put it on a chat box or raise your hand. I think people can put it on the chat box. That would be better. So I'll go ahead with the next talk. So you will realize that these are not watertight compartments. This classification is not a watertight compartment. We need to treat every case on its own merits, isn't it? Can you see my screen now?
Yes, we can. We can. We can.
Sorry?
Yes, sir.
Yeah. Thank you. Thank you. So the most important thing as regards open injuries are concerned is the debridement. And that is the cornerstone of managing open fractures. At the outset, I must sincerely thank our plastic surgeons and my orthopedic surgeon colleagues, as well as our microbiologists and infectious disease specialists. Without their help, I don't think we could have conducted or gathered some experience for conducting this module. I have already discussed that some recent data is very, very disheartening. Now, there are 5 dictums as regards open fractures are concerned, and there is one suggestion. 5 dictums are, the first is, I'm making a bold statement. Many publications tell us the truth, like intramedullary nailing versus external fixation in treatment of open fractures, effectiveness of external fixation, intramedullary nailing after external fixation. All these tell us the truth, but they don't tell us the complete truth. And the complete truth, which is often not discussed much, is it is only after desperate debridement. Then only you could think of any skeletal stabilization. And unfortunately, that has led to a condition where there is tremendous overstress on hardware. Debridement is like a software. It cannot be described. It is subjective. While objective thing, what is seen on X-ray is the hardware. Second dictum is something which this book has explained or discussed or proposed, Standards of Management of Open Fractures by British Orthopaedic Association. And they say, take out the word debridement, replace it with excision of the wound and extension of the wound. This is the book which is has a free access an exceptionally good book by British Orthopaedic Association and British Association of Plastic Surgeons. And they say that think of debridement, don't think of debridement, think of excision, excising the entire wound. For that, you will be helped by extending the wound. The third dictum is don't judge the limb by x-rays. For example, when this patient came to us, the relatives had brought this x-ray only. Sir, we want to take treatment from you. So I said, Arey, this is an extremely well-reduced fracture. And then they showed this photograph. So don't judge the limb by x-rays. A limb is as good as its cover. Fourth dictum, cover the naked limb and naked bone as early as possible. You have ideally 3 days to have a good cover for the bone, max 7 days. And as I said, limb is as good as cover. So convert this into closed fracture as early as possible and partner with plastic people. It is now called orthoplastic treatment or orthoplastic debridement or orthoplastic excision. My suggestion is use tourniquet. This is a bit controversial issue, but certainly helps as far as good debridement is concerned. So what is the roadmap in managing a case of open fracture? I'm talking about the surgical part. Convert it into closed fracture ASAP. Create an environment suitable for fracture union so that it doesn't hinder secondary procedures, avoid complications, and regain function and good cosmetic appearance. I mean, these are our aims. So the first step, a good debridement is more than 1,000 antibiotics. First, good debridement wins the war. And courage during debridement stems from efficient plastic surgery colleagues. So what should be the debridement or excision? It has to be beyond the injury. You cannot just go through this injury, excise everything. Now, it has to be extensile to visualize the damaged muscles, fascia, and bone ends. Very often, people do not explore the bone ends, saying that this is just grade 1 injury. It is necessary to explore the bone ends like this. Whatever end has come out must be explored. Ideally, both the ends should be explored, and because very often the contamination goes into the canal, medullary canal, and then only you will have an adequate debridement. Distally based flaps need to be taken out. One can think of taking out bone graft, skin grafts from there. Now, we come to little more troublesome things, that is fascia. All contaminated fascia needs to be excised. Now, when you have an open fracture with a small facial defect, be very, very careful. It is generally a small piece of bone is protruding out, and one needs to open the fascia completely to assess the underlying muscle, because very often the muscle is injured. Whenever you are treating or suspecting compartment syndrome, one has to release the fascia completely. And whenever there is a vascular repair with an open injury, one must release the facial compartments. As I showed you this case, the muscles, deep muscles, are often non-viable, as you see here. The patient who had hematuria and myoglobinuria, we just explored, we took out this muscle and she settled. So suspect muscle injury when there is a severe swelling, a small facial wound, or a small piece of bone that is protruding out. One must also remember that you can have a superficial viable and deep non-viable muscles. Now these 4 C's, we have been talking about these 4 C's quite often, and there have been recent papers where they say that we often over-treat or over-excise muscles. If you do histopathology of excised muscles, then very often they are alive. But when you are operating, it is impossible to do histopathology. So we may be over-excising muscles, but it is always safer to over-excise than under-excise. Now, all severely contaminated or necrotic bone pieces need to take out. Bleeding bone ends need to be achieved. Loose diaphyseal or metaphyseal pieces need to be excised, what is called a tuck test, while articular cartilage or pieces with articular cartilage, as far as possible, should be saved. We all know that good irrigation is important, and avoid pressure irrigation system, and it is best to use only normal saline. At the end of all this, we should try and obtain cover for nerves, vessels, tendons, and bone, bare bone, as early as possible. And we must avoid dead space, dead tissues, and wound tension. There have been several biological dressings that have been introduced. If we are not able to do primary closure or delayed primary closure or a split thickness graft. Several flaps have been described, and we will discuss that at, I think, in seventh module. Negative pressure wound therapy has become quite popular now, and one very important thing one has to remember, that it should not be used beyond 7 days. Because if the closure is done within 7 days, chances of infection are only about 12%, which increase to almost 57% if the closure or cover is obtained afterwards. If the VAC is continued for more than 7 days, chances of infection become very, very high. Lastly, acute shortening and lengthening is a viable option, especially in people in the hands of surgeons who are quite comfortable with Elizaro. Coming to the last thing, that is skeletal stabilization, which we'll discuss a bit later, but you must try and achieve some skeletal stabilization, which helps in achieving alignment, rotation, and length, and helps the biological process of healing. It should leave small footprints, and that is very, very important. So this is end of one surgical procedure. Something which we very often forget is these two are entirely different things: skeletal stabilization and debridement. So at the end of debridement, it is best to cover the wound, take away all the dirty, contaminated drapings, change your gloves, change your attire, go into new gowns, take another different set for skeletal fixation. Don't use the same set, don't use the same drippings. And lastly, wound cultures. We had asked all of you whether you would take wound cultures or not. More than 50% people have said that they would take wound cultures. Now, there are several articles in the literature, and all of them have stressed this point. Pre as well as post debridement cultures in open fractures are not useful. Another couple of papers that are from India. Here, this is a prospective study of 107 open fractures. The infection rate was 43%. 76% there was growth on initial cultures. But none of the organisms that were grown on admission and pre-debridement eventually cause infection. And that is something very important. They may get infected, but they got infected with a different bug. So it was just useless. And 28% of cases with negative cultures eventually got infected. So it stresses the importance of not taking cultures pre or post debridement, unless you have a classically infected scenario. Then things are different. Another one stressing the same thing. So pre-debridement as well as post-debridement cultures are not very useful. So at the end of first debridement or day one debridement, you re-prepare and drape and go to stabilization of the fracture, and if need be, use vac or cover the skin. Now, we are open to discussion.
Yes, so there are a couple of questions.
Yes.
One by Dr. Subramanya Gandhi. In the pediatric case, was any remnant bone left? I'm assuming you're asking that after we excised the bone, there was no bone in the gap. It was a 7 centimeter bone defect. And with stability and achieving a good clean bed and the appropriate antibiotics, biology started taking over, and first shell of bone was seen posteriorly. And then once the flap was put in, bone started throwing completely within the tube, which is formed by the soft tissue. I hope that answers your question, Dr. Gandhi. Dr. Aisha Mohapatra has a question for you, sir. Regarding Gustilo-Anderson classification, if there is a tear in the gastrocnemius overlying a fracture, would it be a 3A or 3B? And what about repair versus reconstruction or approximation of the gastrocnemius muscle?
I will be discussing a case exactly what you have asked. So just wait for a 15-20 minutes.
Yes. Dr. Akshay, do you have a question? When do you exactly plan sending cultures in open fractures?
When do you?
When do we ask for cultures, sir?
Cultures in open fractures. Yeah. If a patient comes on 4th day and it is it is obviously infected, then you are dealing with an infected fracture and not an open fracture. In infected situation, you need to send cultures. But if somebody comes within, say, 12 hours or 16 hours, and I'm able to excise it completely, I will not take cultures. There cannot be a cutoff zone, but if you do it, you are able to do it in, say, 24 hours, then there is no need to send cultures.
But if a patient comes with a foul swelling, yes, sir.
Exception to that is if there is a contamination with seawater, because there are some weird organisms with seawater and they have to be found out.
Okay. So a lot of times the patients get referred to us after, say, 5-6 days and they are foul smelling. So that we consider infected and send cultures?
Right. Correct.
Okay. Dr. RAV has a question. Is Ganga classification or Ganga scoring internationally used, although he has read it in Rockwood?
It has been published in JBJS and it is internationally accepted score.
Correct. And Dr. Gandhi has one more question. Can VAC be used in infected or contaminated cases? And the second part was after proper debridement?
Yes. Only after proper debridement. That is the basic thing. Okay. Now, may I request Dr. Menon to discuss bugs and drugs in open fractures?
Yes, I'll do that. A couple of questions were, can VAC be used for more than 7 days? And can it be put immediately after debridement, or should we wait for a few days?
As regards VAC is concerned, in open fractures, what I mentioned was in open fractures, if the bone is exposed, then don't use VAC for more than 7 days. However, if you have a covered bone, then one can use it longer time. But a covered bone needs to be, uncovered bone needs to be covered by 7 days, ideally 3 days. Then don't use VAC for more than a week.
And can it be used immediately after debridement, or should we wait for a few days? That is the other question.
It depends on the hypervascularity of the tissues. If the tissues are very vascular and the large part of cancellous bone is exposed, then it is better to wait for some time, otherwise it just sucks out blood. So very often we wait for about 48 hours.
Okay, sir.
Yeah, yeah. Please go ahead, Dr. Menon.
Yes, sir. I'll go ahead. So in this talk, I'll be covering on the bugs and drugs in open fractures, more on the bacteria. So this is we'll go through a case scenario which will help us understand how we can preempt bacteria or bugs related to open injuries. So this is a 43-year-old male who had a forklift injury in an oil field in Middle East. It was an open injury of the proximal tibia. The primary surgeon did a debridement and a bicondylar tibia plating. Unfortunately, there was an early surgical site infection. They debrided but sent a superficial swab, which then grew methicillin-resistant coagulase negative staphylococcus, also called staph epidermidis. It was sensitive to oral clindamycin, which was given, but the infection persisted. This is when the patient came to us at 6 weeks with a persistent discharging sinus, bone exposed anteriorly, and implants in situ. X-rays showed that the implants were pretty stable. There was no obvious osteolysis around the screw sites, but it was not responding to culture-specific antibiotics, as we've seen. The question was why? There was a sensitivity from the swab. The bacteria were sensitive to clindamycin, which was given. Implants were stable. Then why did the infection not settle? To understand that better, this is an animation made by Dr. Raju Gite, who's an orthopedic surgeon who was a fellow with Dr. Agashe. This animation clearly makes us understand what exactly happens in an open injury. So this arrow is like the forklift, with the yellow and blue circles being the environmental or the soil bacteria, and the red circles are your skin commensals, which are present on everyone's skin. When an open injury happens, the skin is penetrated, soft tissue is penetrated, and all these bacteria, the skin commensals as well as the environmental pathogens, go inside, they disperse, they multiply. Then we take a swab. A lot of times we take a swab. The swab is very superficial. We may not actually get the deep bacteria which is growing inside. What we'll get is just the superficial skin contaminant, which is around the skin and soft tissue. That is what has grown in the culture, like was in this case. We give antibiotics to target that skin commensal, which has come out in our swab, and those commensals die with those antibiotics. But the actual environmental pathogens are still there, deep inside. They are not obvious because they're still multiplying. We end up fixing the implant with either a nail or a plate, and we close the wound. Eventually, these bacteria multiply, they form an abscess, and that abscess tries to find a path of least resistance, which then comes out as a discharging sinus, a little away from the original fracture site or the original open injury. And we wonder why, in spite of doing everything, having a stable fixation, why did we fail? This is exactly what happened in this case. So go back to the history. It was an oil field injury with mud contamination. The swab grew coagulase negative staphylococcus, which is a skin commensal. To understand a little better, Dr. Aisha, who's an infectious disease specialist, she will be touching upon this again next week in her talk. I'll just go through it in brief. There are skin commensals like streptococcus, coagulase negative staphylococcus aureus as well, propionobacterium, which grow in the skin. That is one. The other thing that we need to remember is surgical site infection. Whenever there is an early surgical site infection, the bacteria have to be very strong. They have, like staphylococcus, streptococcus, or a gram-negative E. coli, etc. They have to be very virulent to cause such infection so early after surgery. Whereas something like a coagulase negative staphylococcus or a propionobacterium, they're very slow growing and they cause an indolent, almost silent discharging sinus weeks or months or even years after the surgery. So this patient had an early infection, culture grew coagulase negative, which didn't fit. The picture did not fit. Plus there was an open injury. So again, to stress on the aggressive nature of staphylococcus versus coagulase negative staphylococcus, Staphylococcus aureus is like a missile. It has an affinity for host protein and traumatized bone and is the commonest organism isolated, destroys everything around it. Whereas coagulase negative is a slow killer. It causes slow indolent infection. But none of them, not Staphylococcus aureus or coagulase positive staphylococcus or coagulase negative staphylococcus, is associated with contaminated soil injury. They're seen on skin. Skin commensal going in can cause either an aggressive infection or a slow infection, but they are not associated with soil injury. What is seen with soil injury is Clostridium, which can cause gas gangrene, gram-negative pathogens like E. coli, Klebsiella, Enterobacter, Pseudomonas, Acinetobacter, even something like non-tuberculous mycobacteria and fungi. These are the organisms that we commonly associate with soil or environmental injuries. To stress on why we should not use swab is swab gives us only the superficial culture. It does not actually give us a deep biopsy from deep within. So the concordance between, there was a study where the surgeons took a swab, and at the same time, in the same patient, they took a deep tissue culture on debridement, and they compared, and they realized that the match between the superficial swab and deep tissue was in only 1 in 5 cases. So 4 out of 5 cases, the swab gave a completely different bacteria, which does not represent the actual pathogen, and we would have completely missed out on giving the appropriate treatment. So in this case, the culprit could have been completely different. So we decided to explore, remove plates, do stage surgeries. And one thing that we need to remember is Dr. Rajiv Soman, who is a senior infectious disease specialist who was at Hinduja when this case happened, he and Dr. Agashe have formulated a lot of the guidelines. Dr. Rajiv Soman insisted that the story is not complete. This does not fit. The implants have to come out because somewhere we are missing the diagnosis, we are missing the bacteria. So the minute Dr. Agashe opened this, the implants were loose, the screw and tuberosity was excised, there was pus all around. The implants came out, and which is very difficult to explain to a patient, even do as a surgeon. To remove all the implants, it means there's nothing left. We're left with a big hole, like in this case. But only after removing the implant, if you can see in the right side of the image, there's pus within the medullary canal, which he would have otherwise not reached or debrided if he had not excised the dirty cancellous bone and the implants were not removed. Culture grew Enterobacter aerogenes, which is a gram-negative bacillus, which now fits the clinical history. Started on meropenem, given for 6 weeks. Wound bed improved with the debridement and the antibiotics. A knee-spanning external fixator was put. There was a massive bony and soft tissue defect. Dr. Modi did a gastrocnemius flap. Antibiotic cement rods were put in, cement beads were put in. And the minute a good cover was achieved, stability was achieved, appropriate debridement was done, antibiotics were started, we can see this bony formation laterally, medially, as well as posteriorly. The biology just takes over. Cement was removed, the defect was filled with iliac crest autografts, and the patient just never looked back from them. The bony hypertrophy continued. There was excellent consolidation seen at 2 years. This was 7 years, excellent range of movement. The point to note is the tuberosity was excised. The quadriceps tendon was not really sutured because there's no tissue to suture it. The flap covered it and it just fibrosed, and the patient had active knee extension without actually doing anything active for that. So detailed history is important. Avoid a swab stick, do radical debridement, get the right sample. Based on the deep tissue cultures, start the appropriate antibiotics. A good flap gives excellent vascularity, stabilize appropriately either with external or internal fixation. And that is how we decide, or we gauge as to what pathogen have we got, whether it is the correct pathogen. So the history was a crucial, it was a simple history of what the patient told us. Now coming to the basic question, this is when the patient came to us after a few weeks. What when a patient comes to us on day 1, that is the commonest scenario that we see, with an open injury, what antibiotics do we give? Again, going back to the study that Agashe sir has mentioned, the paper by British Orthopaedic and Plastic Surgery on standards for management of open fractures, recently revised in 2020. The primary thing is the good debridement, or what is called excision now. Then comes the role of preemptive antibiotics. Now, preemptive antibiotics means we have preemptive infection and we are giving antibiotics to prevent that. The highlight of this is 3 things. Initiate as soon as possible. 1 day of antibiotics is as effective as 3 to 5 days. So avoid prolonged antibiotics. Keep it short. So what they did was they reviewed a lot of 3B injuries, grade 3B injuries, and realized the infections that happened, which is what is shown in paper shown by Agashe, that the organisms were completely different from the first organisms contaminating. The organisms causing infection were nosocomial or hospital-acquired organisms. So they have suggested 2 phases of antibiotics. The second phase actually targets the organism which eventually causes the infection. and that is given as the definitive wound closure. What the first phase does is it is started as soon as possible, preferably within 1 hour of injury. It is continued till the first wound debridement or the first wound excision. What is given? Simple amoxicillin clavulanate. Co-amoxiclav 1.2 grams, 8 hourly. Sorry, 8 is not mentioned. It's 8 hourly intravenously, or a third generation cephalosporin like ceftriaxone, like a monosef, which is a total of 2 grams daily. Only in a patient with a prior history of MRSA infection, or sometimes we do an MRSA swab for certain patients. If that comes out positive, then add teicoplanin in addition to co-amoxiclav. This co-amoxiclav will cover for MSSA, but it will not cover for MRSA. Teicoplanin specifically covers for MRSA. Add it to the co-amoxiclav or to the ceftriaxone once a day, but that's a single dose. The phase 1 is continued. In addition to this, we have this tendency of giving metronidazole or amikacin. That is not required unless there is a specific contamination like a sewage, foul-smelling wound is there, which for then metronidazole is added for anaerobic cover, or a seawater exposure for Vibrio or certain other antibiotic is added. So this must be discussed with the physician or the microbiologist before adding. Otherwise, stick to either just co-amoxiclav or just third generation cephalosporin like monosef. Nothing else is added. Continue this till the first debridement. At the time of first debridement or the first wound excision, in addition to amoxiclav, gentamicin has to be given for gram-negative cover at 3 milligrams per kg. Nothing else to be repeated. If the surgery extends for more than 3 hours or there is more than 10% blood loss, give an additional dose of amoxicillin clavulanate. Gentamicin need not be repeated. Continue this for 24 hours only. Definitive soft tissue cover with or without stabilization, internal fixation, must be done within 72 hours. They have stressed on this umpteen number of times, unless there are certain specific conditions where either because of the technical issues or the lack of expertise, it is delayed. Otherwise, preferably try and do it within 72 hours. At the time of the definitive soft tissue closure, single dose of teicoplanin is added, plus gentamicin. So these are, teicoplanin covers for MRSA and gentamicin covers for gram-negative. At this stage, co-amoxiclav is not given. Why this change of antibiotics? Because these antibiotics are specifically for organisms which are selected out of the initial prophylaxis and nosocomial. So what does this mean? The amoxicillin clavulanic acid kills simple bacteria like MSSA, but it does not get MRSA. So the MRSA gets selected and starts multiplying, and that can cause an eventual infection, which is what is killed by the teicoplanin. That is why it is selected for that. And gentamicin is added because we get a lot of nosocomial gram-negative infection. So these are the pathogens covered for in the phase 2 of antibiotics. So phase 1 is for common contaminants to be given till the first debridement, continued for 24 hours after that. Second phase is given at the time of the definitive soft tissue closure, ideally within 72 hours, to cover for the nosocomial or selected organisms, and nothing beyond 72 hours. No antibiotics should be given beyond that. So that was as far as the bugs and drugs in open fractures are concerned.
Thank you very much, Dr. Menon. Great talk.
Thank you, sir.
I'm sure there would be some questions, but whatever questions you have, put it on the chat box, and we will go ahead with Dr. Thakur's talk. Now, this is a great honor for me to tell you that this was possibly the first paper from India about external fixation. Way back in, I think it was 81, 83, sir, in Journal of Bone and Joints, 91. So almost 30 years ago. And he and Dr. Joy Patankar had published this paper from Cooper Hospital. So may I request Dr. Thakur to tell us about external fixation in open fractures, paper published 30 years ago.
Yes, sir. So,
in late 80s, external fixator had become quite popular, and we were quite taken up by the ease of application. However, not all the principles were derived, but gradually they were evolving. So we conducted a study of managing open tibial fractures, and we did it as a definitive treatment. And to forestall that the non-union rate, we started doing early bone grafting. This was published in Bone and Joint Surgery, 1991. At that time, it was really rare to get anything published in British Journal from India. And because this study was okay, they probably took it up. We studied, it was a study of using unilateral uniplanar tubular external fixator in 79 open tibial fractures. We treated that. Now, applying external fixator to tibia is very common. Does one type of frame help everything? No, we can do a little discrimination and study the fracture pattern itself. If in AP view you see a butterfly fragment, then the beak of the butterfly fragment is on the tension side and the base is always on the compression side. So if a bending force is applied, the beak happens, and if the beak is if you see the beak butterfly only in AP fragment and nothing in the lateral fragment, then the buckling, the application should be in the coronal plane. Just to recapitulate the planes, the blue sheet is the coronal plane and the sagittal plane is in the pink sheet. So the fixation, the external fixator should be applied in the coronal plane. And that is the way it will go. Now, if you see on AP picture, I think I missed one. If you see only on the lateral side and nothing on the AP picture, that means all the forces were applied into sagittal plane. So your external fixator should be applied in the sagittal plane. When you see a fracture which is got a beak on the medial side, and you can see the butterfly fragment in both AP and lateral side, that means the applied force was from anteromedial to posterolateral side. So your external fixator should come from anteromedial side, which is the most common side we apply. But when this particular pattern is seen, butterfly fragment seen on both sides with the beak on the medial side, it is scientifically correct to apply the external fixator on the anteromedial plane. However, sometimes we see something different, that the beak is on the lateral side. Now, that means the force was applied in the anterolateral to posteromedial side. Now, it is difficult to apply external fixator on the anterolateral side. The soft tissue would be damaged. In that case, to get a good stability, one needs to apply a delta frame. And the two fixator angles and the delta frame, something looks like this. That was just a brief about how to apply external fixator on an open tibial fracture. Our study was of 2 years, prospective study, in which we had those 79 cases, and it was used as a definitive method of treatment from beginning to end to the healing in open tibial fractures. And to cut short the healing time, we resorted to early bone grafting when indicated. Indication was if we did not see any bone formation at the end of 6 to 8 weeks, we would go in for bone grafting. And in all high energy cases, we applied bone grafting at delayed way in around at 8 weeks time. It was a routine to do that. It gave us good pictures. We first analyzed the wounds. And that time, Gastello was there, but somehow we were influenced by the European classification by Matter and Rittman. And again, there are similar grades, but our majority of the cases were medium and high grade injuries. The fracture pattern was against transverse short or comminuted fracture. That means medium and high energy group was treated by us. Now this is a comparison. We have the fracture pattern of on the upside and the soft tissue injury grade is on this side. So we got maximum numbers of medium and high grade injuries of injuries. So it was a fairly severe injury group. With our treatment, we could get healing in type 1 at about 16 weeks, in type 2, 18 weeks, but in type 3, severe injuries, it was delayed up to 26 weeks with a range of 14 to 40 weeks. Our results compared well with other series. Good thing about it was that we allowed full weight bearing at 3.8 weeks on average. But what was most useful or what most impressed the European audience, the freedom of sitting cross-legged and squat was a major advantage. This is the patient photograph, which in my opinion really made the editor choose my paper and publish it. That's my opinion. I don't know what the editor said, but this was the only photograph in the article. This is how it is. Most of our patients came from very poor areas, so they didn't have toilet facilities and other things. So this kind of posture is very useful for them, and the freedom this external fixator gave them that time was very much appreciated. Delayed bone grafting of 6 weeks was the real thing that made the changes. So this is how the paper was published 1991, and it was well received at that time. It has been referenced in about 3 or 4 articles later on, but not more than that. After all, once the internal fixator, the locking plates came into being, the external fixator fell back and things changed. Things change every 10 years anyway. So that's about that paper, which we published in 1991, 31 years now.
Thank you, sir. Very enlightening talk to come up with such papers in 80s and publish in JBJS. We find it difficult to publish it now as well.
Well,
we have a few questions. We can go ahead and where were we? So there's one question by Dr. Sandeep. If we develop cover by fasciocutaneous flap, would VAC will help later? Dr. Sandeep, after the flap, generally VAC is not required. A lot of times plastic surgeons use VAC on skin graft to improve the take-up of the skin graft to reduce hematoma between the graft and the bed. Otherwise, once we've got a flap cover, then generally a VAC is not required. VAC is before the flap is done to improve the bed. Next question. I think one question, Dr. Tarun's question will be answered by Akesh on the Agashi sir. Dr. Arevi, yes, antibiotics, what they have recommended is to be given only for 72 hours. And in continuation, what you have asked is, Dr. Akshay has also asked whether if the patient is on VAC, do we continue antibiotics? Yes, a lot of times we can't achieve cover within 72 hours. So ideally, we should cover only with simple antibiotic like amoxicillin, clavulanate. Sometimes piperacillin, tazobactam has a broad spectrum, but try and keep it as minimal as possible. Do not go to higher antibiotics because higher does not mean better. We'll keep emphasizing on this point through the modules as we go ahead. There was one question on what about grade 1 and grade 2 fractures? It's the same. It is amoxicillin, clavulanate, and these fractures by and large are closed within 1 day. So a 3-dose antibiotic prophylaxis that we use for clean cases is all that is required. Just because it was grade 1, grade 2, having debrided. So even if it is grade 1, it does not mean that we do not debride it. That will again be covered in one of the cases. We must debride the small puncture hole as well, because that contaminant must come out. Otherwise, that contaminant can be a source of infection. And then simple 3 doses within 24 hours is all that is needed. What irrigant might be used. We by and large use saline. Hydrogen or iodine can be used, but there is no one golden solution. Agasha sir, any inputs from your end? Thakur sir, have you found that any other irrigant has given an additional advantage over normal saline?
No, normal saline is all that matters, and the volume is important. As you rightly said, 9 to 10 liters. So more the volume, mechanical cleaning, that is what matters really. And there is no need to add any soap, antibiotic or Savlon to this solution, just plain distilled water or normal saline. That is all that is required for lavage. About mechanical, we said don't use the high pressure lavage, but to pour 9 liters on a wound is quite a painful job. So what I do is I use the machine, but at a low pressure. Those machines have got pressure adjustments, and if we put it on the low pressure, the pain of putting the syringes and blowing them, that goes away and your efficiency increases. At the same time, the dirt does not go inside the muscle, so it works very well. So though the statement is correct to the pressure irrigation system, but the proviso is of the caveat is that use it on pressure and save yourself a lot of trouble.
Correct. So that is what a lot of arthroplasty surgeons also do for periprosthetic infection. Once the implants are removed, the medullary canal is irrigated with the irrigation system, although at a lower pressure, because otherwise we cannot really wash it manually with our hands.
Right. Yeah,
it's very difficult. One question by Dr. Arevi is, saline can be used for retained implant that cannot be removed, or other irrigants can be used for this important retained implant. So retained implant does not mean one must compromise as far as the debridement is concerned, like we showed. If it's beyond a certain time, more than 4 weeks, 6 weeks, then the question is whether we should remove the implant or not. But in case of retained implant, saline is enough. There are a few solutions which are marketed, such as polyhexanide, which are known to have better action against biofilm. So they suggest that you soak the bed for 10 minutes with the solution. But again, saline is the gold standard. By and large, everyone uses that.
Okay.
Agasha, can we go ahead with the talk?
We'll start.
Take the questions after that.
I think so. So as I mentioned, skeletal stabilization is very, very important because it basically controls the movements between fracture segments, reduces pain and bleeding, realigns the fracture fragments, helps early recovery of soft tissues, improves function, and helps fracture healing. The most commonly asked question is, what should you use? Internal fixation like nail or plate, which makes it very, very comfortable, or use an external fixation. If you use a nail, whether you should use reamed or unreamed nail, and with an external fixation, should you use a uniplanar fixator or a biplanar fixator or a modular fixator or a circular fixator or LRS or limb reconstruction system. Now with that, we discussed the case that I had posted. Relatives of this 13-year-old male came with X-ray showing ulna which is protruding out, and there are some shadows which are suggestive of mud. There was no other injury, hemodynamically stable. So basically we discuss only the open fracture. And as you can, as I said, there is a significant contamination in the bone. Will you like to push the bone inside? Majority of you have said they will not. Now when he presented, the bone was already inside and a slab was applied. Second question was, will you like to give a thorough wash in casualty? To which almost everybody, 5/6 have said they would like to give wash in the casualty. Now, most of the recent literature almost insists that you should try and take out only most contaminated things and what this book calls is a social wash. Don't give massage and wash, but if it is too much contaminated, then try and give just pour some saline to take out obvious contaminated area, but avoid giving a thorough wash in casualty because the contaminated material would be shifted inside. Normal saline, almost 3/4 have said they'll use normal saline. How will you proceed? Several questions. What will be your plan for wound management? Is it only thorough wash or local debridement or wound excision without getting bone out or with getting bone out? And majority have said that they would try and take out the bone end and debride it. Will you take cultures at this stage? I have already discussed that. Now, how will you extend the wound? Sorry. How will you extend the wound? Almost 70% have said that they will extend the wound in this way. Some have said that they will extend the wound like this. Very few have said that they will extend the wound with the lateral aspect going proximal and ulnar aspect going distal. And some have said that they will just make a vertical incision. Now, my thinking about it is, if you notice that the radial fracture is proximal and the ulnar fracture is distal, if I have to explore radius and ulna after excising this wound, then I have to have the radial side going proximally and ulnar side going distally. Then only I will be able to approach both these properly. Again, what will be your way we will achieve reduction is by wound extension. Majority have said this, while some have said that they will attempt for a close reduction. Various opinions about how to stabilize. I'll tell you my thinking. So this is how they came. This is how I excised, took the radial incision going proximally so that I could explore the wounds. First, I took the distal incision, explored the ulna first, delivered, and most important, I noticed a piece of or the ulnar spike which had come out, which was grossly contaminated, and I just excised it. Generally, when the bone is grossly contaminated, I just excise that bone rather than trying to clean it. Then rest, everything was decent. Then I worked on both sides of median nerve. You can see that's a median nerve, and then both radius and ulna are exposed here. And I worked on both the sides. Here you can see the ulnar spike I have excised. I have put in nails because plates would have been too extensive. It would need lot of dissection, and only plaster would possibly not give adequate support. Now, since it was not a very good wound to start off because of significant contamination, I kept it open. But on third day, and most important is, I had a good soft tissue cover for the wound. I put a split thickness graft. This is at 4 weeks. This is at 6 weeks. This is at 8 months. Completely consolidated fracture and excellent function. So the crux of the matter was desperate debridement. Excise that bone piece. Now, how does one choose stabilization? When do you decide plate or a nail or external fixation? Contamination of the tissue, cover, and general condition of the patient are the main determinants. If the patient is unstable, there is a gross contamination and soft tissue cover is not possible versus there is a stable patient, minimal contamination, and soft tissue cover over fracture site or implants is possible, then you do an internal fixation versus an unstable patient, you do an external fixation. So if you are not very happy with the wound or patient, do an external fixation to start off on day one. Obviously, internal fixation is very comfortable for everyone. So one tends to do an early conversion to internal fixation. Sometimes it is not possible. Then one may have to continue till fracture healing, as Dr. Thakur has highlighted. Very often, one may have to change the type of external fixator that is used. If there is a problem as regards healing is concerned, then sometimes we may have to do a late conversion of internal fixation. So prerequisites for internal fixation is absolutely clean wound, dead clean wound like this, and a good soft tissue cover of bone as well as implants is possible. Now remember, when you're talking of soft tissue cover, the exact assessment of skin loss can be done only after you have reduced the wound. Otherwise, it tends to broaden the defect. Now, we all know that chances of infection are high as regards internal fixation is concerned, but reoperation is more common with external fixation. Several papers have almost proved that internal fixation, up whenever you are comfortable with the wound and patient, is better. Coming to a clinical example. This patient presented to us, the wound appeared clean. And here again, I suggest that don't go only by wound size, because this was a patient, a stable patient. We decided for a nail, but he was bleeding all throughout the night. And you can see by the time we took him up for surgery in about 5 or 6 hours, there was a severe swelling in 6 hours, and he was continuously bleeding. Now you will notice that the fracture fibula is very, very odd. And now this spike had perforated a branch of posterior tibial, and that is why he was bleeding profusely. So even though the fibula fracture was not open, I had to open on the side of fibula. This is a very funny incision because I had to keep tracing that bleeder. But the wound was good. The plastic surgeon said that he'll be able to do a flap. So we fixed it up with a nail internal fixation. This is at 6 weeks and pretty good healing and excellent result at about 2 years. You can see a well consolidated fracture. So tibia nailing in open fractures. This is a large meta-analysis. It did increase infection rate in 3B, and they have highly recommended to avoid internal fixation in 3B. Ream nailing is better, and somehow they found that grade 2 open tibial fractures treated with unreamed tibia nail, the chances of compartment syndrome were very high. So all in all, they found that unreamed tibia nail has several complications. And that is the time, somewhere around 2010 or 2011, people started moving away from unreamed tibia nailing. Coming to roles of plates. As a general policy, you will realize that nails would not give adequate stability in upper limb. So coming to a case, he presented at 10 hours. Excuse me. Markedly comminuted radius and ulna. Obviously, the ulna was infected, but what was important that he also had compartment syndrome. He had practically no movements. The skin was contused on the ulnar side. The ulna appeared grossly infected. He had no sensations or movements. So what is the thought process? We need to release the compartment. We need to excise the wound so well that we are able to stabilize this fracture on day 1. Though the wound was in fact contaminated, this fracture pattern was most unsuitable for either nail or external fixation. So we decided that we'll try and do a plating. But we had to have an excellent wound. So we just excised the contused wound. We excised the ulna, which was appearing contaminated, created a good bed. So the idea was, as we have discussed, plate the ulna without additional soft tissue damage, try and slide the plate, then do a volar fasciotomy, use that to approach radius and fix the radius after excising to match the ulna. So ulna was excised to gain good wound, radius was excised to match the ulna, and we used radius ulna plates. We closed the ulnar wound, and then the soft tissues would cover the radius plate, and we could do a split thickness graft. So here you can see this was the thinking, and we slided the plate. You can see the wound is extremely clean. This was the volar fasciotomy that we did. This is the level of radius excision we did, and this is the plate on the ulna, and these are the 2 plates we used for radius. Initially we kept the radial wound open. Today I would certainly use VAC for about 72 hours. We grafted at 72 hours. Sensations were normal by 24 hours. All the muscles appeared to be working by about 10 days except flexor pollicis longus. And this is at 6 weeks. This is at 4 months appearance and healing, and that's the function at 4 months. So we could salvage mainly by a very thorough debridement, excising everything that appeared to be infected, going beyond the edges of contaminated area, and then primary internal fixation. So as a general guideline, plates to be used in upper limb and nails to be used in lower limb. Consider external fixation when we have something which is not amenable to internal fixation. Now, when do you use external? Advantages are, of course, when you need a good access for debridement and cover. So initially, we need good exposure, or we need good approach. So it has to be a monoplanar fixation. If there is a bone loss and you need axial stability, or a transport you are planning, then you need to have a ring fixator. Now, doing a ring fixator on day 1 is generally not very easy. So one can use a monolateral fixator and change over to a ring fixator later. And LRS may serve both the functions, but the shank screws need to be in one plane, which may not be possible. Using a monolateral fixator, which Dr. Thakur had said, they had extensively used this, but those were the days when rod-to-rod clamps, which I am showing you here, were not available. So if you have a rod-to-rod clamp, then you can actually reduce the fracture even after passing shank screws using this frame, and you can see a pretty good movement, healing. Most commonly, we use shank screws going from medial to lateral side. Now, the book that I have quoted, they say that chances of neurovascular injury is significant, and it cannot neutralize the force of gravity well. Therefore, what they suggest is passing the shank screws vertically. Now, very often the drill bit is likely to slide. So it is best that you make the first hole just lateral to the crest and put the drill bit perpendicular to the bone so that it doesn't move, but then use that hole and put the shank screw vertically. Remember, for femur and humerus, there is nothing like a safe corridor, because all these screws all the thing will go through the, here you can see they will all go through the muscles, because it is a concentric segment as opposed to an eccentric segment like tibia, where there is a percutaneous or subcutaneous border. Keeping fixator for a long time in femur is difficult. Keeping fixator for a long time in tibia is not all that difficult. We must try and avoid delayed union by getting an auto stabilization, which I will show you now. Now, this patient I have already shown you. Patient presented this way. There was very poor access for debridement, and the debridement was really not done well. The culture was Pseudomonas resistant to everything except colistin, and the fixator wires were through the wound. He was also tobacco chewer and diabetic. So we removed that fixator, used a fixator which would give us good access to the bone. We used to the wound, we used WAC as has been suggested on this forum, and could get a very good soft tissue cover for the bone. And this is at 8 weeks. However, by 12 weeks, the fixator started becoming loose. And here you can see we have a good wound, good cover, but a malposition and delayed union. We kept him in plaster, and at 14 months, you can see the bone has consolidated but malunited, because we tried to get a good reduction. Can one reduce the time in external fixation and malunion? So this 40-year-old man presented on 20th day post-injury. You can see the he had an RTA about 20 days ago. He was unconscious for some time. He was on ventilator. He was admitted somewhere with where the open pelvic fracture was managed. He had to be transfused a lot of blood. The right thigh wound was drained by a drain, and treatment given was an external fixator for femur as well as tibia fibula, suprapubic cystostomy, exploration for fracture pelvis. So when he approached to us, there was frank pus coming out from this area. The culture which was done 2 days ago was positive for Pseudomonas, and he was on meropenem and colistin. There was a purulent discharge from this inguinal wound as well. And he also had malpositioned radius ulna. This is the X-ray presentation for the tibia. This is for femur, and that's the X-ray for open pelvis and closed radius ulna. So the first step is a good debride. You can see we opened that infected degloved wound. That's the skin that was removed. Sample from this area was taken. The open pelvic wound also was explored. And this is after skin excision. This is after post-debridement. And again, we put in negative pressure therapy. Now here, it is not an open fracture. It is an infected fracture. This is 15 days or 2 weeks, 3 weeks, and the culture has already grown Pseudomonas. Now at 3 days, you can see we have an excellent granulation tissue. The growth from the tissue that we have removed is Pseudomonas sensitive only to imipenem and colistin and candida. So we are facing with bad bugs also. Purine also showed candida. And then he was started on colistin, fluconazole and imipenem. This is the wound now. Now the important thing is the external fixator was not giving stability because there was no good bony stability. When you have a situation like this where you will have to continue external fixation for a long time, try and achieve good bony stability. That is what we did. We had a decent wound, so we opened the quadriceps and shoved in this femur inside, like docking. femur inside, and that itself gave fantastic stability. We again changed over to rod clamps. Same thing we did for tibia from outside in a closed manner, and put a split thickness graft on 16th day. This is X-ray at 3 weeks. This is X-rays at 3 weeks, decent skin. X-rays at 9 weeks. On the removal of pelvic fixator, we could mobilize him. The X-ray has started showing good consolidation. This is at 13 weeks. And we removed the fixator at 16 weeks. And this is at 3.5 years. You can see all the fractures have absolutely consolidated, and he has an excellent function, as you can see here. So when you're dealing with a condition where you will have to continue external fixation for a long time, either think of bone graft or shoving the external fixator, shoving the bone ends into one another. But this is a case where there was a question on the group by Dr. Mahapatra, I think. A 23-year-old boy presented 3 weeks later with severe infection. This is a major loss of posterior compartment. As we started cleaning, you can see the gastrocnemius just came down, and there was no neurovascular continuity also. The posterior tibial was completely cut. And most of you have said that you would do an aggressive debridement, Elizaro and segment transport, aggressive debridement, external fixation, and try and involve a plastic surgeon or continue fixator. Now, when there is a massive loss, this is a paper published in 2018, where they have suggested transverse debridement, acute shortening followed by distraction. They had treated almost 30 cases like this over a period of 10 years. And now we had treated this almost 10 years ago. First step is good debridement. Take out everything that is bad. That leads to a big defect. Now, doing a flap is not useful because we cannot get continuity of the gastrocnemius and posterior tibial nerve. Both are extremely important. So we just shortened him. We just shortened him by 4 centimeters. We could approximate the gastrocnemius. We could approximate and repair the posterior tibial nerve. Then all we had to do was a split thickness graft. So we tided over the crisis. From here, loss of gastrocnemius, thorough debridement, shortened him, put a split thickness graft in just a matter of 1 week. From a bad wound, muscle loss to a good cover. And then we lengthened him. Now, this being a posterior wound, it was really difficult to get a good reduction. And unfortunately, though we got a good regenerate, the fracture went into non-union. Now, my colleague, Dr. Vivek Shetty, said that let's do a ream nailing, because I was a little concerned that it had to go through the regenerate bone. But we could achieve this, and this is him at 18 months, and this is him at 7 years with a decent sensations distally. Now, very often one needs to keep changing the fixator. Another bomb blast victim, another bad culture pattern. He presented with a monolateral fixator, rigid fixator, no good reduction. We changed over to a rod-to-rod system and biplanar fixator. This is post-debridement. Fixed the fibula so that also acted as a support. Split thickness graft at 1 month with a local rotation flap to cover this bone defect, and we had tied it over the crisis. Now, we have a clean wound, clean cavity with a good cover. Can we shift the fibula? A very nice paper in Zebides 2001 says that if you shift the fibula, the bone formation is fantastic in this case. So we shifted the fibula. Now this is a too thin, flimsy fibula. What is going to happen? Nothing. Within no time, sheets of bone started forming, and we shifted over to orthofix fixator for convenience. And this is him at 4 years. No bone graft, nothing. And he just healed. So finally coming to conversion of external fixator to internal fixation. If the unstable patient becomes stable or wound condition improves, then try and do it as early as possible, preferably within few days, so that chances of pin tract infection are less. But if you convert late, then you may need a lucid period of about 3 weeks or so. Just to illustrate that point, this was a patient who presented 48 hours later with obviously infected wound. This is post debridement. We have a clean wound, but here the infection was already there. So I continued with an external fixation. Unfortunately, the patient went into non-union. Here you can see it opened up. So at 3 weeks, I had to convert it into a formal nailing. I had to do quadriceps release at that time. And then here you can see at 2 years, she has an excellent function. So to a take-home point, stable patient, clean, wound achieved, try and do primary internal fixation. Too sick a patient, too sick a limb, put a primary external fixation, tide over the crisis, try and do an early conversion, which is relatively safe. But if that is not possible, try and you may be forced to do late conversion, which is little more risky because chances of pin tract infection are high. Thank you, friends. And I think Dr. Thakur can sum up now whatever we have discussed today. I stop sharing, sir. You can keep posting the questions on the chat box as well as on the group.
So as we come to the end of today's module, what did we learn? We started with a new philosophy of 6
No, you're not sharing your screen, sir.
Okay, there's nothing to share on the screen.
Okay, I will share the screen then. 1 minute.
I know no presentation here. It's just my.
Okay.
So we first got introduced to this problem with the new philosophy of tabletop for an infection with the 6-legged stool and all the 6 factors and the burden on it. It is a novel idea, and that gives us a comprehensive thinking about how to manage these things. Then we learned about the historical classification by of the fractures, and later on we moved to Ganga Hospital classification, which is a development from the original classification, which was just the beginning. It was evolved to a Ganga classification. I find Ganga classification is very comprehensive and is useful to guide us to get some outcome. It is outcome related. It's not just academic, but it guides us what to do with the limb. So more and more people are now using Ganga classification. And if you have to start using a classification, that's the way to go. Then we had all the 5 dictums of managing an infected fracture. After that, we had a roadmap of the primary debridement, how to go step by step, and what is a good debridement, when it should be done. All that was discussed. That the concept of VAC has made a lot of change to infected wounds, and that has been highlighted in today's talk, when to use VAC and how effective it is. After that, the debridement comes the bacteria, and we had a very good talk on what to expect in bacteriology and how to collect cultures and how to manage that. Mixed infection post. Then we had a very good case about oil field injury, in which it was practically highlighted how things come to you and what you should be doing in stepwise region. What is most important is when not to take culture, when to take culture, and then how to organize your antibiotic. That itself is a science that we need to learn in greater detail. And as we go along, more and more things would be discussed about selection of antibiotic and usefulness. Later on, we went having debrided and got rid of the infection. Then we had to stabilize it to get a healing. And that was discussed in this last section of giving when to use a nail, when to use a plate, and when to use an external fixator. And lastly, we got an algorithm when and where, how and where. So that was all that we did today. Would conclude today's session after we have answered all the questions for today.
Thank you, sir. Thank you. Dr. Aditya?
Yes, sir. Thank you, sir. So there are quite a few questions lined up on the chat box. We'll take it one by one. Question to both Thakur sir and Agashi sir. When there is a wedge break laterally, would tense nail, like stacking the tense nail away from the wound, would that be appropriate with debridement? And then soft tissue cover followed by definitive fixation with bone grafting at 6 weeks? Or an external fixator compared to a stacking tense nail primarily?
Sir, you will go or I should answer?
You go.
Okay. Now, if the wound is good, then I would definitely prefer internal fixation. If at all the wound is not very good, I will prefer an external fixation. Having said this, the tense nail generally do not give rotational stability. So you would land up putting an internal fixation, but not getting adequate rotational stability. Tense nail are extremely useful when the soft tissue envelope is good. But if the soft tissue envelope is not good, I would prefer a standard interlocking nail. Does that answer the question?
Yes, sir. So what you're saying is we are committing to internal fixation. We might as well commit to the ideal implant rather than choosing something.
Correct.
Okay. So next question is by same by Dr. Tanay again. As external fixation from anterolateral side can damage the tibialis anterior, is there any trick to avoid it?
Anterolateral side. Why would
anterolateral side?
Why would you put anterolateral side? It's not a safe corridor. When the forces have acted from anterolateral to posteromedial, the way to do is to use a delta frame. That means put two shank screws at an angle and connect it with a rod, as I had shown in that picture. It is exactly what is to be avoided. You can't damage a muscle with external fixator. Put a delta frame instead.
I think he is little confused with this slide, if I'm not mistaken. Have I shared? Can you see this?
No.
Or you can't?
No, you can't.
Okay, I'll just share the screen. Now, I have realized what he's trying to say.
The anterior pin.
Yes. I think, Dr. Tanay, can you see my presentation?
Yes, we can.
Yes. So what I am trying to illustrate here is we always used to put pin from medial side. Now what they advocate is passing a pin just medial to the tibial crest and not anterolateral. Not like this, but not like this. Pass it just medial to the anterior tibial crest, vertically. So does that answer your question? So try and avoid putting pin from the lateral side, pin or shank screw, putting from lateral side. You could use one frame like this and another frame like this. Yeah.
In case one is choosing an elixir or fixator, a pin is described from the anterolateral. So one must put a thumb on the tendon, retract it, take a small stab, and then put the wire. The elixir or wire.
Or keep the ankle in dorsiflexion and then put the wire.
Okay. There was one question by Dr. Durgesh. In distal tibia fractures, if we excise the soft tissue, even if for a puncture wound, the tibia would get exposed. So what do we do in such situations? Especially he's saying that he does not have access to a plastic surgeon, then it becomes difficult to do that.
Correct. So generally, when there is a puncture wound, you excise an elliptical part, and more often than not, 99% of the times, you will be able to close it. Because you have taken a lazy S incision, and it's not very difficult to, even in tibia, you will be able to close it, if it is a puncture wound.
Okay, got it. We'll try and share diagrams of the lazy S incision on the WhatsApp group, so it becomes easier to understand. Next question is by Dr. Aisha. In facilities with delayed transfer to OT, what should be done in case? One, with bone jutting out of puncture wound in casualty and death, or can the sequence be excision, irrigation, primary debridement of both ends, and soft tissue tissue can be done in casualty? Should we do any procedure in casualty? I think that is what she's trying to ask. Should we do any debridement, push the bone back in?
That's going to be very, very difficult doing it in casualty. Unless you have good, what is called trauma theater. There are many hospitals which have trauma theater next to casualty, and general anesthesia facilities as well as aseptic precautions can be taken there. Otherwise, try and avoid doing anything without anesthesia.
Okay. I think what she's trying to say is even if trauma OT is not available for various medico-social reasons. Yes, sir.
Another thing is we should avoid doing midnight surgeries. Usually, major trauma centers would tide over between 11 and 6 in the morning. They will not have any major debridement issues. They will just conserve for time being and then do it at proper time. Unless it is life-threatening, major surgeries are usually not done at night.
Sir, I tend to differ with you. What you are saying is an ideal condition. Unfortunately, in our country, the general hospitals are so overburdened that the seniors would insist that all the open fractures to be operated immediately so that next day's list is not hampered. So that is why the people at a junior level should learn managing open fractures well.
True, but then we are putting patients at risk. We are putting patients at risk, and we have seen that many times happening. So we should at least discuss what is good.
Yes, agreed.
And practicality may be different, but if we keep on discussing good things, hopefully one of these days the administrators will help you to get into the ideal condition. Very busy centers, Leicester General, I remember. They wouldn't do anything between midnight and morning. Whatever happened, it was all managed in trauma ward and then bring it up at the right time. So it is possible, it is just a matter of organization, but at least in principle, in discussion, we must bring out.
Yes.
So if I could give a middle path, that avoid anything in the casualty without anesthesia, even jutting, putting the bone back in. Get the ideal time to take the patient in the theater, even if a few hours later. If you can't do it in the morning, do it at night, but in the theater. And if possible, post the patient in the morning in the routine list, unless there is a neurovascular injury or gross foul-smelling sewage contamination. I think these are 3-4 conditions where urgent debridement has to be done.
Or compartment syndrome.
Compartment syndrome. We'll share that document as well, the BAPRA's open fracture, open injury document on the group. Next question by Dr. Tarun was, in open fractures with bone loss, what would you prefer, acute shortening or maintaining the length? So is there a guideline, sir, for docking? What is the limit to which we can dock in one go?
Generally 3 to 4 centimeters in tibia, 4 to 5 centimeters in femur is max you can dock. Otherwise, the vessels will get kinked and chances of this thing are high. So whenever you are trying to dock, the foot has to be kept exposed, one hand has to be on pulse, and then start docking. The frame has to be applied first and slowly, don't suddenly shorten, slowly dock. Very often I dock over 2 or 3 days rather than doing it in one go.
Actually, so we apply the fixator and accelerated docking in the ward a centimeter a day with the height of the pulse. And the patient is awake, so he can tell you whether he's feeling any tingling or not.
Correct.
Next question is Dr. Akshay has asked regarding one of the cases we showed where the tibia and femur both were fixed with an external fixator. Why not the one with the pelvic injury? Why not shift to a nail once the infection had settled? Why continue with the fixator? Is there any criteria or guideline?
As you notice, the culture pattern was really not very good. And yes, the infection had come under control, but by then we had started mobilizing his knee. Another important thing is he was with a pelvic fixator for almost 3 months because it was grossly unstable, and therefore there was no way we could mobilize him even partial weight bearing. He also had a fracture radius ulna, so that way we could not have mobilized him with a nail. And especially with this culture pattern, I would not like to take a risk of putting in a nail.
Especially with fungal infections?
Fungal infection.
Next question was, is rod-to-rod fixator needed only in delta planes, or should we use it for any fixator?
Every fixator, try and use a rod-to-rod fixator, a rod-to-rod clamp, so that you are able to get a good reduction.
Sorry. Yeah. Okay. In case 2 with neurovascular laceration with loss of posterior tibial nerve, after 3 weeks, what's the state of circulation and neurology? In that case, what was the status?
Sorry, I didn't get you.
In the second case with neurovascular injury, where the posterior tibial nerve was injured, what was the circulatory and neurological status at 3 weeks?
The dorsalis pedis was felt. There was decent sensations on the dorsum. There was hardly any sensation on the sole.
Okay.
And
next
posterior
question.
tibial artery also was cut.
So the dictum that there is no sensation on the sole appetite doesn't hold true.
Correct. Correct.
Okay. Another question by Dr. Arevi is, how was the fibula shifted? Was it like a bone graft completely excised and then transported to the tibia space, or was it gradually done?
Very, very good question. Just open only for osteotomizing the fibula. Don't open completely like a bone graft. Keep the muscles intact over the fibula. Then use Ellis arrow, beaded wires, pass through the tibia, through the fibula, and take them out from tibial side, and use a slotted threaded rod to shift the fibula. Generally, the tibial, there is significant fibrosis on the posterior medial aspect of tibia, which prevents this, and therefore very often one has to take an incision on the tibia also, open that fibrous tissue and get the fibula in. I think I will draw and send it on the group.
Okay. So Gandhi has requested if he could share a video of how to do a proper debridement for a contaminated 3A or 3B. Maybe we could share some videos of the planning of debridement for the next few weeks.
I think during the session on osteomyelitis, we will be sharing a video of debridement. Yes. I think the principles are almost same.
Correct. If there is external fixator and flap for wound, do we have to wait for flap to heal before converting to internal fixation?
If the wound is absolutely good, then generally about 7-8 days, the flap starts settling, and then you can put an internal fixation. Having said this, I very often, if I have a wound which is absolutely good and I intend to convert it to internal fixation, I would do it before the flap. I will put in an internal fixation and then rotate a flap. That becomes very, very convenient and in fact safer.
Okay. Because we are assuming that by the time the internal fixation is planned, the wound is healthy, so even a flap can be done at that stage.
Correct.
And how much shortening can be accepted? I'm assuming it's overall shortening. Not very clear on that.
Yes. Generally, 2 centimeters patients do not have much of a problem. They can wear a raise and they are very comfortable. So if there's a question between tiding over the crisis, question between very bad wound and shortening, I would prefer shortening rather than keeping that wound there. And if need be, we can always lengthen.
All right. Question for Thakur sir to re-explain the butterfly fragment concept for external fixation by Dr. Durgesh.
So I think sir can put it on the group. Those drawings can be put on the group.
Okay. When to convert external fixation to internal fixation after wound healing?
See, means before plastic surgery, we should convert into internal. If you are planning for internal fixation, then the best time is before doing a flap. If you think that you are not comfortable, you may have to continue external fixation, then do a flap and continue external fixation.
Okay.
But yeah.
Okay, I think it covers all the questions in the group.
Yes. Okay, friends. Dr. Aditya?
Yes,
you can sum up now and call it a day.
I think before I sum up, there's one last question by Dr. Aniket. Malunited tibia, did you do any deformity correction to one of the patients we showed, sir? I think we tried to trace him, but the patient was happy clinically.
Yes.
He was walking.
Yeah. He was very happy.
Although ideally he required, but patient was clinically stable. He did not want to go another surgery after having gone through multiple previous surgeries. Okay. Thank you to all the delegates who've taken out time to join this first session. And all of you have introduced yourselves. I think if you were left out in the next session, before we start, if we can have the introductions for the others. Thakur sir, thank you so much for giving your valuable time and your inputs. The paper in the 1980s published in JBS is an eye-opener for all of us. We struggle to publish even today papers in international journals, but it shows that if we have the right methodology, we can get it done. Thank you, Agashe sir, for your insight and the great clinical cases. It's an eye-opener for all of us. I still learn from you every day. And I think that should wrap up our session, the first module. And next meeting, we'll have Dr. Aisha, who will be touching on the bacteria and the antibiotics part of it. We'll try and make it as clinically oriented, case-based, so that it's not a lot of theory. Bacteria and microbes are something we stay away from. We'll try and keep it interesting. Thank you, sir.
Okay.
And thank
Bye-bye.
you, everyone.
Good night to everybody. Bye.
Thank you, sir.
Thank you, sir.
Thank you.